Good afternoon, everybody. So today's discussion will cover two topics, sulfonamides and fluoroquinolones. So we'll begin with the first topic, that is sulfonamides. So these were one of the first antibacterial agents to be used, and Gerard Domac is associated with the discovery of sulfonamide. He had actually used a dye called as prontosil red, which was containing a sulfonamide compound for treating streptococcal infection in mice. And he had cured the mice of the streptococcal infection. And later on, this dye was also used for treating a septicemia in a child. And following this, he has also received a Nobel Prize for Physiology and Medicine. So that is about the history of sulfonamides. But before we go into the sulfonamides details, let me tell you that these antibacterials, being one of the first used antibacterial agents, many of the bacteria have developed resistance against these drugs because they have been used for such a long period of time. So now their popularity has become somewhat less as compared to the initial years. So the classification of sulfonamides is based on their duration of action into short acting, which act for 4 to 8 hours. Example is sulfadiazine. Intermediate acting ones, that is sulfamethoxazole, and long acting ones, which are having a duration of action about 7 days, sulfadoxine and sulfamethoxyrazine. There are other sulfonamides which are used for some special purposes, which we'll be seeing towards the later part of this session. Examples are sulfacetamide, sulfasalazine, silver sulfadiazine, and muffinide. So let us look into the mechanism of action of sulfonamides. The sulfonamides are principally acting as an inhibitor of the enzyme folate synthase. Now, you all know that the bacteria synthesize their own folic acid, which is very essential for their growth and multiplication. Now, how does the bacteria prepare folic acid is described now. That is, they synthesize folic acid from the raw material PABA, which is taken up from the medium. And this PABA is converted into dihydrofolic acid using the enzyme folate synthase. And this dihydrofolic acid is converted to the active form tetrahydrofolic acid by another enzyme, that is dihydrofolate reductase. Now, sulfonamides, they are structurally similar to PABA. And now they will be competitively, they will inhibit folate synthase, so that the folic acid is not formed, and as a result, all the metabolic reactions will suffer. Being similar to the PABA, they may also sometimes incorporate into the folic acid form, and this will be a structurally abnormal folic acid, and that will also not have the normal function. So whenever you are asked to write the mechanism of action of sulfonamides, you are supposed to be showing this flow chart and then describing this process of folic acid synthesis by the bacteria and how this sulfonamide is inhibiting the process of folic acid synthesis. The spectrum of sulfonamides includes gram-positive and gram-negative bacteria. And by now, you must be knowing some of the examples of gram-positive and gram-negative bacteria from your microbiology classes. So you have to give examples accordingly. So the first thing that you have to write is that they are active both against the gram-positive and the gram-negative bacteria. And all these sulfonamides are bacteriostatic. They prevent the multiplication of the bacteria. So the examples of bacteria which are sensitive to sulfonamides are some gram-positive ones like Streptococcus pyogenes. Then you have got a number of gram-negative ones like Haemophilus influenza, Haemophilus ducreyi, then Calimobacterium granulomatis, Vibrio cholera, Chlamydia, Actinomyces, Nocardia, Toxoplasma, and so on. So when we write the uses of sulfonamides, you will be seeing the diseases or the infections which are caused by these organisms. Now, I told you in the beginning of the class that many of the bacteria have developed resistance against sulfonamides. Now, how do these bacteria develop resistance? This is mainly by producing increased quantity of the PABA. So already you know that the competitive antagonism is always superseded by increased production of the substrate or the agonist. So they can produce increased amount of PABA, which can overcome the inhibition due to sulfonamide. Some bacteria have got folate synthase enzyme with less affinity to sulfonamides, and some have developed alternate pathway of folate metabolism. So by all these mechanisms, the bacteria can develop resistance to sulfonamides. Now let us look at the pharmacokinetics. So all these sulfonamides are absorbed very well from the GIT. Their plasma protein binding capacity will differ. And the ones which are having a high plasma protein binding capacity, they are longer acting. The ones that we saw acting for one more, like intermediate acting ones and the longer acting ones, they are having a higher plasma protein binding capacity. They are widely distributed in the body and they can enter all kinds of serous cavity. They can pass through the blood-brain barrier. They can cross the placental barrier. They are metabolized in the liver by the process of acetylation, and the acetylated metabolites are less soluble in acidic urine and they can precipitate to cause crystalluria. So as a mandatory rule, whenever you are prescribing sulfonamides, it is advisable to ask the patient to drink lots of water so that this particular metabolite can be excreted out of the kidney and it will not end up in causing crystalluria. The ADRs of sulfonamides mainly include GIT ADRs like nausea, vomiting, epigastric pain. One of the most notable ADRs are the hypersensitivity reactions like rashes, urticaria, drug fever, photosensitization, severe hypersensitivity reactions like Stevens-Johnson syndrome, which you are seeing here. Okay, it's affecting the skin and the mucous membrane. It's a very severe form of hypersensitivity reaction. People can also develop exfoliative dermatitis. So always whenever you're prescribing this sulfonamide, always ask for any history of allergy to sulfonamides. And many of the patients might also tell you voluntarily that they are allergic to sulfa drugs. So this is a hint that you have to be prescribing that very carefully in individuals. Then as I told you, they can end up with crystalluria. And in premature infants, if you are giving sulfonamides, it can lead to kernicterus. Kernicterus, already you know, it is because of the deposition of the bilirubin in the CNS. So these sulfonamides, they can displace the bilirubin from plasma protein binding sites. And this premature infants, their blood-brain barrier is not well developed. So this displaced bilirubin can cross the blood-brain barrier into the CNS and end up with kernicterus. So this is more prone in premature infants who are having not well-formed blood-brain barrier. And also these premature infants, they are prone to a lot of hemolysis during the initial days, and that results in the accumulation of a lot of bilirubin in the blood. And this bilirubin, if you're giving sulfonamides for any infection to this particular infant who already has a lot of bilirubin in his blood, these sulfonamides can displace the bilirubin, which can cross a not so well-formed blood-brain barrier and end up in kernicterus. Sulfonamides can also cause hemolysis in G6PD deficient patients. So one of the questions that you usually get is name some drugs which can cause hemolysis in G6PD deficient patients. So example of one of the drugs is sulfonamides. Then hepatitis is rarely seen. Now let us look at the uses of sulfonamides. So let me tell you at this point that systemic uses of sulfonamides for bacterial infections is not popular because of the development of resistance by various bacteria. Now they are used, sulfonamides are not singly used. They are used along with trimethoprim in CO-TRIMOXAZOLE, about which you will be learning in the next few slides. So now sulfonamides are resorted only for special uses, which I'll be telling you now. For example, silver sulfadiazine. It is one of the common topical agent which is used for burns and ulcers. And you will be seeing this particular cream being used in surgery departments. If you ever go to your clinical postings, you will see this being used for patients with burns and ulcers. Then sulfacetamide is eye drops, which are used for trachoma, inclusion conjunctivitis, ophthalmia neonatorum. All these eye infections are caused by the chlamydia. Sulfasalazine is used for ulcerative colitis and rheumatoid arthritis. So these are some of the special uses of sulfonamides which are being nowadays resorted to. Now we come to co-trimoxazole. Now this is a very, very common question that is asked for your exams, and you have to be very thorough with the co-trimoxazole. So first of all, what is this co-trimoxazole? So as the name suggests, it's a combination of sulfamethoxazole, which is an intermediate acting sulfonamide, and trimethoprim. This trimethoprim is a diaminopyrimidine. And this combination is in the ratio of 5:1. That is sulfamethoxazole 5 and trimethoprim 1. That is the ratio. So whenever you're starting a short note on co-trimoxazole, you're supposed to begin with what it is. Then what are the advantages of co-trimoxazole over single sulfonamide? That is, this pair is synergistic. The combination is bactericidal. I told you sulfonamide individually is bacteriostatic, but when you combine it with trimethoprim, the combination becomes bactericidal. It also has got a broader antibacterial spectrum. We'll see the additional spectrum in the coming slides. And also this combination doesn't develop resistance very fast. So what is the mechanism of action of co-trimoxazole? So it causes a sequential blockade of folic acid synthesis pathway. So already I told you the pathway of folic acid synthesis by the bacteria, that is PABA to dihydrofolic acid to tetrahydrofolic acid, by the enzyme folate synthase, the first step, and the second step is by dihydrofolate reductase. Now this sulfonamide you already know will inhibit the first enzyme. Trimethoprim inhibits the second enzyme in the pathway of folic acid synthesis. So you're seeing a sequential blockade of folic acid synthesis. So once the folic acid is not there for the bacteria, all the metabolic reactions will suffer and it will end up in the death of the bacteria. Now, what is the additional spectrum? So whatever spectrum we have studied in the sulfonamides, that will be there. Other than that, we have a set of new bacteria against which this combination is useful. So the examples are Salmonella typhi, Serratia, and a number of enterobacteria, the gram-negative bacteria like Klebsiella. Then you have got Pneumocystis jirovecii, Yersinia, Shigella, Gonococci, E. coli, Staph aureus. Staph aureus is a gram-positive one, and many of the gram-positive Staph aureus had developed resistance to sulfonamide, but they become susceptible to this combination. So you can already, by now you must be knowing the uses also. See, Shigella, it causes a lot of diarrhea. E. coli is one of the most common agents causing the UTI. Gonococci, already you know, it can cause the gonorrhea. Pneumocystis jirovecii causes pneumonia in AIDS patients. Klebsiella is one of the causative agents for UTI. Salmonella typhi is causing enteric fever. So once you know the spectrum, automatically you will know the uses of the co-trimoxazole. So urinary tract infections caused by E. coli, then Klebsiella. You can have respiratory tract infections caused by Streptococcus, then Staph. Prostatitis also, this co-trimoxazole gets accumulated in the prostate to very high concentration. So it is very useful for prostatitis caused by E. coli, Klebsiella. For typhoid fever also, this is very useful. Diarrhea and dysentery caused by invasive E. coli, Shigella, Salmonella. It is useful for nocardiasis. It is useful for sexually transmitted diseases like chancroid. In case of gonorrhea, the usefulness has decrease a little bit, but it is still used for chancroid. And in pneumonia, because of the Pneumocystis jirovecii in AIDS patients, co-trimoxazole finds its uses. The ADR include GIT ADRs like nausea and vomiting, hypersensitivity reactions like rashes, and these rashes for some reasons are more commonly seen in HIV patients who are treated with co-trimoxazole. Then megaloblastic anemia also can occur. Uremia, this is more seen in patients who are having renal disease. Bone marrow toxicity again is more seen with patients, HIV patients treated with CO-TRIMOXAZOLE. And thrombocytopenia also seen more in elderly patients and HIV patients who are treated with CO-TRIMOXAZOLE. It is contraindicated in pregnancy. So that finishes sulfonamides and CO-TRIMOXAZOLE. And in that topic, it is the CO-TRIMOXAZOLE which is more important from the examination point of view as well as for your clinical use also. It is a CO-TRIMOXAZOLE which is important, and you have to be thorough with the CO-TRIMOXAZOLE. So whenever in case of chemotherapy, whenever you're writing an answer, your answer a drug should have the class to which it belongs, then the mechanism of action should be there, and the spectrum should be there. So when you begin a spectrum, you should always write whether it is a bacteriostatic drug or a cidal drug, whether it is acting against gram-positive, gram-negative, or anaerobes, or both, or whatever. That is the thing. And then you give the examples of the different bacteria against which it is acting. Then you write the uses, then you write the ADR. And if you remember, you can write the important pharmacokinetic features and the dose also. This is the format in which you will be writing the chemotherapy drugs. Now we go to the next topic, that is fluoroquinolones. So initially we had synthetic antimicrobial agents like quinolones, which were developed. And the example of the quinolone was nalidixic acid. Now this was there acting against a lot of gram-negative bacteria for a long time. But since many of the bacteria developed resistance against nalidixic acid, it is no longer popularly used. Now we are having fluoroquinolones, which are quinolone antimicrobials with one or more fluorine substitution. So that is fluoroquinolone. They are classified into first generation and second generation. We just leave the examples of first generation and the second generation. Ciprofloxacin, Norfloxacin, Ofloxacin, and PHARMACOKINETICS are the examples of first generation. Lomefloxacin, Moxifloxacin, Gemifloxacin, Prulifloxacin, Lomefloxacin, and Sparfloxacin are examples of second generation fluoroquinolones. Now, how are these different? The first generation was introduced before 1980s, around 1980s, and the other one in 1990s. The first generation ones have got one fluoro substitution, whereas second generation one have got additional fluoro substitution, more than one, and other substitutions also. The first generation ones are mainly active against gram-negative, whereas the second generation ones are more broad spectrum. They are active against not only gram-negative, but also gram-positive and anaerobes. The first generation ones have a shorter T-half, whereas the second ones are having a longer T-half. These are the basic differences between the first generation and the second generation. So the mechanism of action is the same for both generations. And this is the first thing that you will be writing. They will inhibit the bacterial DNA gyrase in the gram-negative bacteria and topoisomerase IV in gram-positive bacteria. In the previous, your first year, you already know DNA gyrase is involved in the nicking of the double-stranded DNA, and then it introduces the negative supercoils and then reseals the double-stranded DNA. This is a normal function of DNA gyrase in gram-negative bacteria, and the topoisomerase IV has a similar function in the gram-positive bacteria. Now, DNA gyrase has got two subunits, that is A and B. So the nicking part is done by the A subunit. The supercoils, negative supercoils are introduced by the B subunit, and the resealing again is done by the A subunit. So the fluoroquinolones, they bind to A subunit of the DNA gyrase and interfere with the nicking or the strand cutting and the resealing function. So as a result, what happens is damaged DNA is produced, and this damaged DNA sends some signals which results in the production of exonucleases that digest the damaged DNA. This is the full mechanism of action of fluoroquinolones. Now, the topoisomerase 2 is present in the case of human cells, and this is not getting affected by the fluoroquinolones. So we do not have much toxicity on the human cells. So we'll begin with ciprofloxacin, and this can be considered as a prototype drug for this class. And based on this only, we'll be comparing the other drugs later on. This is the most potent first generation fluoroquinolone. Its spectrum includes mainly the gram-negative bacteria. All these are bactericidal drugs. And the highly susceptible ones are E. coli, Klebsiella, Enterobacter, Salmonella typhi, Shigella, Proteus, Neisseria, H. influenza, Haemophilus ducrei, Vibrio cholera. So you can see more of the gram-negative ones are there. And moderate susceptible ones include Pseudomonas, Listeria, Brucella, and a gram-positive one like Staph. All these fluoroquinolones, they have got a long post-antibiotic effect. That means even when the course of this antibiotic is over, their effect will be lasting. So one of the features associated with fluoroquinolones is the post-antibiotic effect. The ciprofloxacin has got a rapid oral absorption. The food can delay the absorption, so you have to space the timing of the drug and the food. It has got a good tissue penetration, but it is not penetrating the CSF and aqueous humor too much. It is excreted in the urine, and the adverse effects include mainly gastrointestinal ones like nausea, vomiting, bad taste, and anorexia. Occasionally, you can have dizziness, headache, restlessness, anxiety, insomnia, impairment of concentration. Sometimes some individuals can develop hypersensitivity reactions. And in children, tendinitis and tendon rupture can be seen. So for this reason, it is to be contraindicated in pregnancy and in children because of this risk of tendon rupture and tendinitis. So this can affect the weight-bearing joints and the growth of the bones. Otherwise, this drug is nearly having a good safety record. Now, ciprofloxacin is a metabolic, it's an enzyme inhibitor that you have learned in general pharmacology classes. So it inhibits the metabolism of drugs like theophylline, which is used in bronchial asthma. Then it can inhibit the metabolism of warfarin, which is an oral anticoagulant. So the levels of these drugs can increase, and there can lead to toxicity of these drugs. NSAIDs can enhance the fluoroquinolone toxicity. Antacid, sucralfate, and iron salts can reduce the fluoroquinolone absorption. These are the prominent drug interactions and very important drug interactions of ciprofloxacin, and this should be mentioned in a short note on ciprofloxacin. The uses include UTI by E. coli, Klebsiella, Proteus, gonorrhea, chancroid, bacterial gastroenteritis by E. coli, Shigella, Salmonella. It is a very prominent drug for typhoid or enteric fever. Usually, the dose is 750 milligram twice daily for 10 days. It causes quick defervescence, early relief from symptoms, and it can also prevent the carrier state of enteric fever. Now, other antibiotics that we mentioned for enteric fever include CO-TRIMOXAZOLE. Other than that, there are other drugs like ceftriaxone, chloramphenicol, then azithromycin, which you will be learning in the coming up classes. Other uses include bone, soft tissue infections, gynecological and wound infections, which are caused principally by some gram-negative bacteria and resistant Staph aureus. It is one of the drugs of choice for anthrax. It is also used for gram-negative septicemias, meningitis, and topically it is used as drops for conjunctivitis due to gram-negative bacteria. But all these you have to learn, and you can see the principal uses are in infections caused by gram-negative bacteria. So that finishes ciprofloxacin. Now we'll discuss about the other drugs. So we are only mentioning the prominent features. So norfloxacin, it is the least potent fluoroquinolone, and for that reason, and the tissue concentrations are very less for this drug. It is mainly used for urinary tract and genital tract infections and some of the bacterial diarrheas. The usual dose is 400 milligram twice a day, and the number of days depends upon for what infection you are treating. Then you have got ofloxacin, another first generation fluoroquinolone, which is less active than ciprofloxacin for gram-negative bacteria, but it finds more use on gram-positive bacteria and anaerobes. Another thing that has to be recorded is that it is active against chlamydia, mycoplasma, Mycobacterium tuberculosis and Mycobacterium leprae. So they find use in respiratory infections, chlamydia, urethritis, atypical pneumonia caused by mycoplasma. It is also used for orodental infections caused by gram-negative bacteria, and it is also a part of the multi-drug therapy for tuberculosis and leprosy. Now we come to the second generation fluoroquinolones. So one of the first one is the levofloxacin, which is actually a levoisomer of the first generation fluoroquinolone, ofloxacin. It has got, as we already told you, the second generation ones have got more activity on both gram-positive also. So this is one drug which is having a high oral bioavailability. That is, it is nearly 100%. So the bioavailability will be same with the oral as well as the IV routes. It doesn't inhibit the metabolism of other drugs much. And single daily dose is sufficient because of its high bioavailability. It is usually used for respiratory infections like community-acquired pneumonia, chronic bronchitis, sinusitis. Then being active on the gram-negative bacteria, it is also used for UTI. This is also used for chlamydial urethritis, and this is also used for MDR tuberculosis. So far you have seen ofloxacin being used for MDR tuberculosis, levofloxacin being used for MDR for tuberculosis. Then Lomefloxacin and Sparfloxacin these are the two second generation fluoroquinolones which have been taken off from the markets because of QT prolongation risk. Next, we have got Moxifloxacin. The most important thing to be observed here, it's the most active fluoroquinolone against Mycobacterium tuberculosis. And so it is one of the very common drugs which is used for tuberculosis in the multi-drug regimens. This also has some tendency of QT prolongation and phototoxicity, but comparatively less as with Lomefloxacin and Sparfloxacin. Ciprofloxacin and Prulifloxacin. These are two broad spectrum second generation fluoroquinolones. They are also finding use mainly in community acquired pneumonias and bronchitis. Prulifloxacin also used for UTI. So these are all active against gram positive, gram negative, including the resistant ones. These also have got some ADRs like GI disturbances and CNS disturbances, but gemifloxacin also can cause some QT prolongation, but not much QT prolongation is seen with prulifloxacin. So usually the question that you get is the short note on ciprofloxacin, where you have to write completely about the mechanism of action and other things that we have mentioned under that. When you get a short note on second generation fluoroquinolones, please start writing from the mechanism of action. Then you mention about individual drugs and then their corresponding uses. So often when individual drugs are used, you forget that the mechanism of action is the same for all the drugs and you skip that. And when you write the second generation, you only have a few lines to write. So please write the common things initially as a part of the short note, and then only write the prominent, the special features of individual drugs. So with that, we have finished the topic. So if any doubts are there, you may contact me. Thank you.